Osteoarthritis is the most common arthritic disorder, impacting 30 million or roughly 9% of Americans. It generally results in the erosion of cartilage between bone joints of the body, and cartilage acts as a sort of cushion or soft pillow between bones so that we move with ease during our daily activities. Over time, and if we pick up more weight, bone spurs and a gradual narrowing of the gap between bone joints of the knee, hip, and hands can occur. This can cause pain, swelling, and increased stiffness, such that we can't move as well as we used to. Now, medically, the severity of osteoarthritis is ranked nominally through 4 stages. Stage 1 is considered minor, up to stages 3 and 4, which are considered moderate and severe, where there is virtually bone on bone contact. Extremely painful. So, we want to avoid that kind of pain at all costs. The good news is that there are a number of therapies we can employ to help osteoarthritis patients delay the symptoms of this disorder and improve their quality of life. The first of these therapies are called NSAIDs, or non-steroidal anti-inflammatory drugs. I know, long name. We'll use NSAIDs for short. But popular agents include Advil or Aleve, and they are often taken by mouth, typically with food, because these drugs are known to cause an upset stomach with some patients. But there is hope. NSAIDs can be administered topically on the skin with a medication called Voltaren 1% gel. This is available over the counter at your local pharmacy. There is also a second kind of NSAID called Celebrex, and that drug works a bit differently than Aleve or Advil, where you can resolve pain and inflammation without causing as much stomach discomfort. Now, if NSAIDs ever posed a problem, or Voltaren 1% gel was ineffective, or perhaps there was an aspirin or NSAID allergy, some providers recommend Tylenol. However, that medicine only addresses pain, not so much inflammation. Now, the second class of drugs are injectable corticosteroids. Rest assured, these are not like anabolic steroids associated with bodybuilding, as these injectable corticosteroids act on a different receptor. These agents are often injected in the affected joint every few months to help relieve pain and inflammation. However, there may be a transient increase in blood sugar, so diabetic patients, please speak with your provider. The third group of agents are opioids. These are extremely powerful for pain relief, but are technically controlled substances. This means these agents carry a substantial risk of drug dependence, addiction, and tolerance over time. Finally, there are also alternative agents where the data from clinical studies are a bit inconclusive or off-label with respect to their clinical benefit for osteoarthritis. The first drug on that list is Cymbalta, which is a popular pain drug for different types of nerve pain and mental health disorders. The second agent is capsaicin cream, which is available over the counter. And when this agent is applied to the skin, it literally feels red hot, like a chili pepper, the seasoning, not the rock band. But it does make sense because chili peppers were actually sourced to develop the active ingredient for capsaicin cream. It's just that the efficacy of this agent is questionable at this time. Finally, hyaluronic acid derivative drugs like Synvis, Hyalgan, and the like are often injected into the knee like corticosteroids to provide relief. But in some studies, these drugs were actually no more effective than placebo in some patients. Therefore, while they do have an active indication for osteoarthritis, there is no known evidence that one particular HAD drug is more beneficial than another. Looking to the future, there are new biologic agents on the horizon. These are called anti-nerve growth factor antibodies. The first is called tanezumab from Eli Lilly, and the other is fasinumab from Regeneron. These two agents will sort of act like a light switch along the pain pathway, effectively turning pain signals off before they reach the brain. Currently, clinical studies are ongoing, so we won't know the adverse effect profile until FDA approval is granted. We also won't know whether the subcutaneous injections will have to be administered by a provider for the medical benefit or self-administered by the patient under their prescription benefit. With formulary decisions in mind, these new monoclonal antibodies will likely be reserved for our most moderate to severe stage 3 or 4 level osteoarthritis patients. Payers would be prudent to require step therapy in favor of guidelines supporting use of NSAIDs and injectable corticosteroids first before experimenting with any new and likely less cost-effective hyaluronic acid derivative or anti-nerve growth factor antibody therapy. With that, thank you for listening to the Clinical Minute. Have a great day.